And there was a lot of great information shared. So I think our afternoon speakers will be just as engaging and informative to you. So to start us off this afternoon, it's my pleasure to introduce Katie Brundage. She's this close to PhD, but we can't call her doctor officially yet. A neuropsychology resident, Rush University Medical Center. She's going to be sharing information about at the corner of Alzheimer's disease and behavioral health. So Katie, I will turn it over to you. Thank you.
Thank you very much. And I appreciate you acknowledging how close I am. Um, so I will be discussing, again, at the corner of Alzheimer's disease and behavioral health, specifically talking about some common symptoms that we find in individuals with Alzheimer's disease that seem to be very difficult to not only address, but continue to address because sometimes they could be quite dynamic. So first, going over the learning objectives for my presentation, I hope we will all be able to recognize common behavioral and psychiatric symptoms in Alzheimer's disease, including delusions, hallucinations, agitation, and depression. Understand the impact of these symptoms on individuals with Alzheimer's disease and their caregivers, and learn about practical person-centered approaches to management of these behavioral symptoms. I have no disclosures. And in the interest of time, again, I'm only really going to be focused on these three major behavioral and psychological symptoms. I won't be covering topics such as sleep disturbances, inappropriate sexual behaviors, and wandering. Happy to discuss if there's any additional time or any specific questions. But I do encourage folks that the number of the articles that I'll be referencing do include information on these and other behavioral and psychological symptoms. And an additional note, I am not a prescribing provider and don't plan to be, but I will be reviewing some of the literature on some of the pharmacological interventions, as well as best practices based on the current research. It's important to approach these symptoms because they can be complex and, again, like I said, ever evolving from many different avenues. And it's important to kind of talk about the whole spectrum of what we can do to help treat our patients. However, a lot of the literature has supported first line being these non-pharmacological interventions, but it's important to note the pharmacological as well. Again, I've included citations at the end in each slide, as well as a list of citations at the end for reference for anyone having any additional questions, as of course, not being a prescribing provider, it is not my area of expertise. But I wanted to first highlight that though some of these symptoms, behavioral and psychological symptoms, are very difficult to manage in individuals with Alzheimer's disease, they are inherently a part of the criteria in order to meet for dementia, here presented on the slide, as well as included in the specific Alzheimer's disease diagnosis. So though it is, again, difficult to manage, and we hope that our patients don't have these very complex and sometimes difficult to treat symptoms, it is inherently a normal, quote unquote, part of the Alzheimer's disease diagnosis and progression. So therefore, we need to be aware of what's currently presented in the literature, even if sometimes it is inconsistent or ever evolving. So continuing to go to presentations like this and hearing what is currently being reviewed in the literature is important, not only for good quality of care, but being informed in terms of the trajectory of some of these symptoms and where and when they present and how best to treat them. So first, discussing delusions. So in this review article that I will be referencing a couple of times in today's presentation, the prevalence ranges from 9% in the literature to 59%, with this kind of average hovering over around 31%. Delusions are these fixed false beliefs, often paranoid in nature, and they can include things like believing someone is stealing items, believing that the patient is in danger, believing that caregivers are not who they say they are. They're not my daughter, they're not my spouse. There are these imposters. In addition to feeling like a caregiver is going to abandon them or is not having their best interest in mind for some reason. They know who they are, but they're not actually doing what they say they're going to do. And why I'm presenting delusions and hallucinations together is, at least in my clinical experience, they sometimes go hand in hand, that they'll start off first with a delusion, but then hallucinations then present themselves as well. So hallucinations, a little bit less high prevalence in terms of the average, around 16%, but that range being between 6% and 41%. And hallucinations are in seeing, hearing, or sensing things that aren't there. Hallucinations are considered one of the most frequent psychotic symptoms of Alzheimer's disease. Again, why I included both delusions and hallucinations together in today's presentation. And hallucinations are mainly visual and auditory in nature in Alzheimer's disease, but somatic, olfactory, and tactile experiences have also been reported in the literature. And even, for example, I had a patient a couple of months ago who first started off with having very concrete visual and auditory hallucinations. And then, as her disease progressed, she started having more olfactory hallucinations, specifically because her family was noting that they could not see what she was seeing, and the hallucinations transformed. And so now she was no longer seeing these individuals who were presenting in her home, but she was able to smell them, or was reporting she was able to smell them. But regardless of the sensory modality, hallucinations are associated with higher cognitive impairment, more rapid deterioration, as well as increased mortality. And these changes, this onset of hallucinations as well as delusions, have been noted in some neuroimaging studies as specific changes in the brain in terms of frontal lobes as well as anterior cingulate cortex, disrupting the ability to distinguish reality from internal thoughts or perceptions. Sensory impairments like poor vision or hearing may also impact the likelihood of hallucinations occurring in individuals. But they could be things like, again, talking to people who aren't there, or seeing people or objects who aren't there, or tasting things or smelling odors that aren't present. So these symptoms can be deeply distressing, not only for the patient and confusing or frightening for caregivers. They are not a sign of someone losing touch traditionally in the psychiatric sense when we talk about delusions or hallucinations, but rather sometimes they're results of changes happening in the brain itself, specifically when we're talking about things like environmental factors. When individuals may be misperceiving lighting or misperceiving objects in a space and perceiving them as being someone in the home, that may be more due to, again, a brain change or a sensory change as opposed to it being a loss of reality. Again, doing things like improving lighting in someone's home, reducing clutter, labeling spaces clearly to decrease confusion. And for caregivers, it's very easy to say, like the example I gave with my patient recently, oh, mom, I don't see that. No, you don't know what you're talking about. You're wrong. But allowing caregivers to give the space to not to avoid confrontation, and instead direct and also avoid direct correction, but instead using things like validation and redirection. Let's check together, let's sit down and have some tea, validating the patient's emotions. It sounds like you're really distressed right now. I'm really sorry that you're feeling that way. And identifying, again, any triggers that are happening, things like mirrors, TV shows that are misinterpreted as real, if there's a certain place in the house in which the patient is frequently having these delusions or hallucinations, is there a way that we can avoid that room or only go in that room when supervised? In addition to things like routine, so consistent schedules to help lower anxiety and help orient the person. And in terms of pharmacological, again, if it gets to the point where some of these delusions or hallucinations are distressing or dangerous, antipsychotics may be considered in severe cases, but they do carry a black box warning for increased mortality. And some possible, in terms of literature that I've been able to review as a part of this presentation preparation, some findings on anti-cholinergic inhibitors have been found to have some support, as well as memantine, but again, some of the literature is mixed. Now, transitioning to talking about agitation, Its prevalence is about 40% on average in the population, and agitation can manifest in a wide variety of behaviors. Sometimes it can present in verbal ways, so things like shouting, cursing. It also can present in other aspects like physical aggression, hitting or kicking, restlessness like pacing or fidgeting, as well as repetitive behaviors or even just refusing care. It's important to note that this isn't necessarily a patient having a bad day. These behaviors often reflect a deep emotional distress or potentially unmet needs that the person can no longer express clearly or not able to signal in a way that is clear to a caregiver or an individual. Um, and this usually happens again because the individual is unable to articulate that they're having some type of physical discomfort, things like pain, hunger, or even things like needing to use the restroom, as well as changes in routine, things like being overstimulated or unfamiliar with environments. It may be in a similar environment, but they're not oriented to the environment, so they're perceiving this change in their routine, as well as someone from neuropsychology acknowledging frustration with cognitive impairment, right? That they're not necessarily able to operate through the world from a cognitive perspective in the same way, and this starts adding to frustration, then leading to these kind of outbursts, whether that again be verbal, physical, or just general restlessness. And in terms of neurologically, agitation has been linked to changes in the frontal cortex, insula, and amygdala. Again, these regions that regulate emotion as well as determine threat response. So when it comes to managing agitation, it's important to again provide caregivers with support, which I know we'll be talking more about caregiver support in a little bit. But allowing patients the ability, or caregivers of patients, the ability to kind of walk through certain frameworks. So, what exactly is happening in the moment, looking for triggers in terms of changes to the patient's routine, help develop a plan to help, again, alter the environment or increase predictability, and then determine whether or not some of these steps have helped. But again, providing safe outlets, such as giving the patient routine tasks to do, things like folding towels, walking around the neighborhood supervised, or walking around the property supervised to get some of that frustration and energy out, that restlessness especially. And trying your best, though sometimes it's not possible for caregivers to control everything in the environment. Reducing overstimulation, so limiting noise, lighting, new novel people, or if you are going to have any of those things, doing them in small bits and increments, and really engaging the patient in patient-centered activities based on past hobbies or interests, things that the individual enjoyed doing, that again is an outlet in which they could feel a sense of, even though they're maybe having frustration with other aspects of their day-to-day, that they're feeling a sense of accomplishment. And again, encouraging caregivers to calmly communicate, validate. And the biggest thing when it comes to agitation is sometimes these nonverbal cues, the kind of body language awareness, and making sure that when a caregiver is approaching or interacting with a patient that is showing signs of aggression, that you're really trying to de-escalate as much as possible, not only in what they say, but as well as kind of how they approach the situation from a physical perspective. And in terms of pharmacological interventions, again, possible benefit from antipsychotics if necessary. And there has been this mixed evidence with antidepressants, specifically SSRIs like citalopram, have been shown to have modest benefit from agitation, for agitation rather, in Alzheimer's disease, but also again carry risks, such as heart rhythm changes and worsening agitation, worsening cognition, which again can kind of act as this self-fulfilling prophecy, with frustration for cognitive changes potentially being a source of some of this agitation in individuals with Alzheimer's disease. Next, I would like to talk about depression, and for the I wanted to talk about both apathy in depression as well as depression traditionally, because apathy and depression represent two distinct syndromes, though distinguishing between the two can be challenging, not only for the patient, but us as clinicians as well. And certain features may overlap, such as diminished interest, psychomotor slowing, and fatigue. Um, and not to spoil the ending, but some of the non pharmacological management of both apathy and depression can look similar. So I did include that together. But I thought it was important to first discuss these two syndromes separately, as again, some of the unique features can impact the application of some of these non pharmacological and pharmacological interventions. So, apathy is actually the most common behavioral psychological symptom of dementia. It's prominent and sometimes persistent across all stages of Alzheimer's disease, is an independent contributor to decreased functional status in patients with Alzheimer's disease, and may increase the risk of conversion to Alzheimer's disease in patients with mild cognitive impairment. So that can present itself as things like loss or diminished motivation, less likely to initiate conversation, less interest or less enthusiastic about usual interests or hobbies, reduced participation in social activities, so not necessarily only about communication, but kind of that physical engagement as well, wanting to go to a friend's house or a community center the way that they used to, and loss of spontaneous emotion or less emotion response to both positive and negative events, so that less reactivity when it comes to usual daily functioning. And neuroimaging studies have correlated symptoms of apathy with alterations in both the structure and functional activity of frontal subcortical circuits, such as the anterior cingulate circuit, which is involved in motivation, and the medial orbital frontal circuit. Now, talking about depression, again, these symptoms that are more unique to depression are things like pessimism, depressed mood, such as sadness or hopelessness, poor appetite with weight loss, disturbed sleep, crying spells, feelings of guilt, again, this psychomotor agitation or slowing, irritability, fatigue, as well as thoughts of death and feelings of worthlessness. And before I discuss some of the interventions, I think it's important to note, especially with a lot of research going into the link between depression and Alzheimer's disease, to acknowledge some of the proposed mechanisms of this link between depression and Alzheimer's disease. I apologize if the graphic that I copied from the review article that I have listed on the screen is too small, but I will walk you through the different stages that have been proposed in the literature. So the first top one, the causative mechanism, it's thought that chronic stress and depression cause neuroinflammation, and therefore that increases the risk of Alzheimer's disease. And elevated pro-inflammatory cytokines damage the brain via neurotoxicity, disrupted serotonin pathways, blood-brain barrier breakdown, and vascular remodeling. And so depression accelerates brain aging, possibly triggering Alzheimer's disease in susceptible individuals. So that's that first mechanism proposed. Mechanism B, it proposes rather a bidirectional mechanism. Therefore, that Alzheimer's disease pathology, meaning amyloid beta and tau, contributes to depressive symptoms. Depression may promote Alzheimer's disease pathology, specifically when depressive symptoms are persistent in an individual. And so studies show minimal depressive symptoms can predict future cognitive decline and are partially mediated by amyloid levels. Individuals with higher amyloid and tau are more reactive to stress, therefore increasing depression risks in this second mechanism proposed. And the third mechanism proposed in the literature, it's that rather there's shared mechanisms, so that depression and Alzheimer's disease share overlapping biological pathways, including things like genetic risk factors, hippocampal atrophy, neurovascular dysfunction, reduced adult hippocampal neurogenesis, as well as functional changes in the brain, especially in areas such as the default mode network. And these shared features can explain the frequent co-occurrence in similar symptoms like apathy, memory issues, and mood instability. And so rather that it's this shared mechanism rather than one influencing the other. However, another mechanism proposed in the literature talks about this chance comorbidities, that some overlap between depression and Alzheimer's disease may occur solely by coincidence, especially in older adults where both are common. And not all co occurring depression and dementia are causality related. Careful diagnosis and longitudinal tracking are really essential in parsing this apart. And a lot of the studies that have been supporting this mechanism, especially, encourage that continue, again, careful diagnosis and longitudinal tracking. And the last mechanism proposed, again, in this review article, was these genetic factors. So instead of talking about shared mechanisms, is that instead there is this reciprocal genetic liability, and that genetic risk of depression may increase susceptibility to Alzheimer's disease. A genetic risk for Alzheimer's disease may predispose individuals to depression, especially things like late life depression. And studies have identified shared variants involving not only inflammation and endogenesis, but other genetic factors. So I encourage especially those individuals who are working with patients, Alzheimer's disease patients who have this emergence of late life depression, to encourage to look at this review article, because it is definitely a summary of a very complex article. But in terms of first helping manage these depressive symptoms from a non-pharmacological, this first line response, it's not surprising that across both apathy and this traditional depressive symptoms, that psychotherapy or cognitive behavioral approaches is the first step. So things like cognitive behavioral therapy, or things like problem solving therapy, PST, which is a brief intervention that involves providing individuals with tools that they need to identify and solve problems that arise from big and small life stressors. In additional to things like interpersonal therapy, so focusing on changes in roles, meaning changes in level of independence, needing to be cared for by a loved one or a caregiver, as well as things like processing grief, this kind of living through this change goals, as well as problem adaptation therapy, or PATH, combines both problem solving and environmental supports, and it's been adapted for people with cognitive impairment. So it's been not only helpful for just the apathy and depression intervention, but also just general kind of adjustment to disease, as literature has found to be helpful. But also doing things like pleasant activities in the individual's life. It's important to note that sometimes, from a cognitive perspective, a patient may used to have engaged in a hobby or activity that was meaningful to them, but from a cognitive perspective, it is more difficult to engage in that. So some of the literature looking at pleasant activities have rather asked the individual to now rate what pleasant activities they would like to engage in. Things that they want to learn, things that they want to do, things that they want to become more independent with in terms of their day-to-day life. And instead having it be that those things are engaged in, as opposed to things in the past. That ends up being more meaningful to them. It's something that they're motivated to do now versus something that may have caused frustration and therefore a lack of engagement, leading to some of these symptoms of apathy and depression. As well as wanting to build these small moments of joy in the day-to-day life. And again, if something is meaningful now, that's going to bring a little bit more of a positive aspect to their day-to-day functioning. Also, things like music therapy, so both passive listening as well as active participation can lift a mood. So things like tapping along to some music, or being able to actively, if the individual is able to, actively choose what type of music they listen to, whether it be looking through records or CDs, or selecting from a tablet or an iPad. Wanting to, again, have that both not only passive listening, but wanting to engage and essentially engage in things that they are motivated to actually engage in. And social engagement, so things like simple structured visits or phone calls can be helpful. And then in terms of pharmacological interventions, for apathy, there's not been any consistent evidence for any agent. Antidepressants, again, cholinesterase inhibitors, memantine, and some other medications may be options, but there really has been mixed results in Alzheimer's disease. Some, again, may help, especially those with a history of major depression, but again, many carry side effects, not only for, again, for the intervention of for apathy, but as well as depression. And I know we'll be talking about caregivers, but I wanted to make sure that we also talk about, especially when we're talking about risk, that we're talking about the risk for and the usual occurrence of depression in caregivers, so especially if caregivers are family members, biological family members, and we talked about these mechanisms increasing risk for Alzheimer's disease when depression is present. It's important as clinicians to provide support to caregivers as well as inform them on ways in which they could help reduce some of these symptoms, because it's this self-fulfilling prophecy in a way if we can kind of early intervention, which is my area of clinical interest, is how can we help reduce risk in the future. So encouraging caregivers to let family and friends help them. So taking others on offers to help and asking for help when they need it, seeking out caregiver support, things like respite services, local caregiver support groups, and online communities. So building a support network to keep a caregiver from feeling isolated. Things like journaling, expressing both the negative and positive emotions of being a caregiver in a journal is a great avenue, not only to kind of get your thoughts on paper and process information, but to get it kind of off your mind and reoriented to the tasks needed to do to be be a caregiver. Additionally, things like trying your best to manage stress the best you can and relax. I feel like I always say to patients trying things like meditation, and they say, I can't quiet my brain or I don't have enough time to do it. But meditation doesn't have to be quiet. It could be things like going for a walk and kind of thinking, being in the present and hearing the birds and listening to the trees, right? A more active kind of meditation, or things like yoga or other methods in which, again, bring the individual some kind of respite as well as a reset. And again, doing things that the caregiver enjoys, where they have time, scheduling that time in, and making sure that they're integrating the best that they can to reorient. And again, the biggest thing is when caregivers are biologically related, wanting to make sure that we're, again, reducing risk where we can. So, kind of to summarize these three areas, it's important, like I have mentioned, to acknowledge that these symptoms, which I really liked this prevalence of neuropsychiatric symptoms in Alzheimer's disease summary table, that again, these symptoms are challenging, they are ever evolving, they can ebb and flow in terms of the disease progression. That it is important to acknowledge in our patients that these are difficult to manage, and they are, again, the literature is unfortunately inconsistent sometimes with some of the areas and aspects of how to best intervene, but really being present with our patients and their caregivers to try your best to address when possible as these symptoms ebb and flow, but really also acknowledging that those, even though that these symptoms are in fact, difficult to manage, they are a part of the disease progression, and being aware and doing some proactivity in terms of setting things up for success, so that some of these symptoms, especially in areas in which there are, again, environmental triggers or precipitating factors that can play into some of these onset, that you're informing patients and their loved ones of things that they could do before things start to get bad. But additionally, in addition to the references that I will include at the end, wanting to acknowledge some additional resources and support networks, So the Alzheimer's Association has a great number of resources for many stages of the journey, including information for local caregiver support groups, as well as their 24-hour line. I've heard not only from patients, but as well as some of my own family members, how helpful some of these resources has been, especially the 24-hour line. Um, Managing some of these symptoms, especially the first onset of some of these symptoms, is hard to manage, and sometimes caregivers are unable to contact us for whatever reason. So providing them with some immediate help, as well as anticipating the best you can in terms of in some of these routine care appointments. But also encouraging patients and their loved ones to participate in research both locally and nationally if they can. There needs to be more research in the space, as I have kind of implied, especially when it comes to things like pharmacological intervention, or even so the combination of pharmacological and non-pharmacological interventions. For those of you who work with individuals with things like depression, usually some of these interventions are best for individuals not with Alzheimer's disease. There's a lot of research to support this kind of dual approach from both the pharmacological and non-pharmacological, and that research has not really been translated in terms of the Alzheimer's disease space, especially when it comes to when there's additional factors. I talked a lot of these symptoms like they happen kind of in isolation, but sometimes they can happen all together. So additional research needs to happen, especially again when some of these overlapping, or again the pharmacological intervention space. So locally, and I'm affiliated with them, but Nathan Klein Institute has some ongoing research. I included the QR code they were able to share with me. Looking into not only late life major depression as a risk of abnormal aging, but some other studies that they conduct as well as looking at national institutions. So the National Institute of Aging also has additional resources, as well as additional research opportunities, or at least they did last I checked. And the biggest thing for them, though, is they do provide some brochures on some of these symptoms, as well as general information that I have given to patients and their loved ones. And that's been very helpful, especially when it comes to, again, my loved one or the patient is not having these symptoms now, but if it were to happen, what would I need to do, or what some kind of quick things that a patient can walk away from. That being said, I want to thank you all again for your attention. I wanted to again give some space if there was any specific questions about any of these symptoms, or some of the symptoms that I wasn't able to cover. Again, like I had promised, I have a reference QR code there on the left-hand side of your screen, as well as my contact information, as well as on the right-hand side of the screen. If you have some time to give some presentation feedback, I'm always open to that. But thank you again for all of your attention, and open to any questions or specific examples that folks would like to walk through.
Sorry, trying to get back off mute. There are two questions in the Q&A. They are combined, or I should say related or connected. It was if a family member is in a memory care unit and manifests agitation only when grooming is necessary, so bathing, changing undergarments, shaving, teeth brushing, how can we get the staff to help handle this? They keep pushing for medication, but we have told them to step back, change the activity if possible, and de-escalate. And then sort of a follow-up to that also is the unit wants to send him to the emergency department if they feel he will hurt himself or others. However, he won't because he calms once he's left alone. So sending him to the ED would be counterproductive. Do you have any suggestions for that?
Yeah, so I first want to acknowledge, yes, I agree that I think going to the ED would kind of escalate something that sounds like it de-escalates totally fine when left independent. It really sounds like there is maybe an aspect of the grooming that is, again, highlighting this factor of frustration of loss of independence. So depending on the kind of cognitive ability, or how able the individual is able to communicate their needs, kind of walking through step by step what is going to be happening during this grooming routine. Hey, so and so, I'm coming in today and I'm going to be helping you brush your teeth today. And so we are going to grab your toothbrush and we're going to grab your toothpaste and we're going to brush your teeth. Would you like to put the, put the toothpaste on the toothbrush? Would you like to turn the water on? The you and the individuals at the facility probably know better than I in terms of the level of independence, but where you can give them independence, giving them independence to again help reduce that level of frustration. Taking breaks, saying, "Hey, I'm gonna have you hold the razor while I get things prepped, but I'm gonna shave your face for you. Hey, can you choose between this razor or this shaving cream or that shaving cream?" Again, promoting as much as you can, as safe as you can, this level of independence without putting the person in any harm's way in terms of things like that. Again, having them be a more active, and I know it's hard in a facility, but having them be a more active participant in terms of their daily care. Things like, does the temperature feel okay? Can you stick your hand out? And do you feel comfortable? Can you take your shirt off for me? I'm going to lift your shirt up this much. Can you do the rest of the way? Again, trying to break things down the best that you can or they can. I've also had patients, because you may have more time in terms of certain aspects of grooming, having a loved one or someone that has the time and ability to kind of take this process and make it multi-step. Having that be something that every time you go and visit that you help, dad shave or you help wash their hair or blow dry their hair. Again, trying your best to help minimize frustration as much as possible and try to communicate with them as much as possible, especially if they're not able to communicate for themselves, to again try your best to reduce frustration as much as possible. I want to acknowledge though that this, especially agitation, is not only hard to manage, but it's also hard to predict in terms of what's going to be a trigger when, because it may not always be a trigger. But especially in this example, the fact that once you leave the your loved one alone, they are able to de-escalate themselves, calm down. So that's not necessarily that there's something else internally going on, right? It's not like they're in pain or there's something else happening. It may be more this loss of independence and the frustration coming from that. But great question, and feel free to ask any additional if you have.
Thank you. If anybody else has any questions, please feel free to pop them in for Katie. That was a wonderful presentation. Thank you so much for breaking that down. And I think it was really a great, in depth. And Dr. Cohen talked about a little bit of some of those things this morning as well. So it was yours is a nice segue into some of the more psychological, emotional components of the disease, the behavioral. Okay, so I'm not seeing any more questions, so I'll say thank you so much. Everybody, please take the time to give Katie feedback and look at her references if you need that for any reason. And Katie, thank you so much for being here today. I really appreciate it.
Not a problem. Thank you.
Thanks. My pleasure now is to introduce Paola Oganda, who is the Director of Social Work from Montefiore Center of Excellence for Alzheimer's Disease. She's going to be talking about the role of caregivers in Alzheimer's treatment. And then after Paola's done, we're going to hear back from Jeff on his caregiving journey. So Paola, it's nice to see you.
Nice
I'll
to see
turn the
you.
floor over to you. Thank you.
Thank you. Thank you, everyone, for joining us today in this very important symposium with so many good information, so much good information. I'm gonna, Erin, share my screen. Let me see if I here can, 1 second. Okay, share this. Let's see. Let me do a right click here. Let's see. Okay. Let's see what I can do. Right click. Let's see.
I think at the top left, if you
At the
just
top.
click from beginning, that'll start your slideshow for you.
Yeah. And I want to like hide the notes. Can I do presenter?
I think if you do that from the beginning, I think
Oh,
it will hide your notes.
okay. Let me see. Okay.
Yes, we can't see your
Okay.
notes.
Okay. Oh,
Uh,
you cannot or you can?
we cannot, so you're all set.
Okay. All right. All right.
Thank you.
Perfect. Thank you. Okay. This technology, I tell you. All right. Well, thank you, everyone, for joining. My name is Paolo Gando, and I am Social Work Director and Care Coordinator at our Montefiore Center of Excellence for Alzheimer's Disease. I am very honored to have this role within Montefiore and be, embedded in the practice in working with our care partners, our caregivers, and their loved ones. And today I want to talk about a group of people whose impact is profound, but often invisible. Caregivers of people living with Alzheimer's. As many of you know, Alzheimer's is more than just memory loss. It's a progressive, life-altering disease, and it unfolds. One thing becomes very clear. Caregivers are absolutely essential. Alzheimer's doesn't just affect the person diagnosed, it ripples through families, friendships, and communities. And at the center of that ripple, holding everything together, is usually a caregiver, often a spouse, adult child, or a close relative, doing their best every single day, often with little recognition or support. And here today, we'll explore the many roles they play, the challenges they face as well, and why supporting them is key to better care for those living with Alzheimer's. Okay. Caregivers are the backbone of Alzheimer's care, and their emotional, physical, and financial burdens need more awareness and support. In Alzheimer's caregiving, the role of a caregiver is multifaceted, encompassing physical assistance, emotional support, and advocacy for the person with dementia. Caregivers help with daily living tasks, medication, management, and ensure the individual's safety and well-being. They also play a crucial role in preserving the person's dignity and independence, which is very important, while simultaneously navigating the emotional and logistical challenges of caregiving. As we see here, caregivers help with bathing, dressing, eating, and helping them with mobility, whether that is transferring their loved one from the bed to a chair to the couch. It's also important to maintain a routine, which is vital for their well-being. It can also provide a sense of stability and independence for the individual. It can help minimize any agitation, confusion, anxiety, and having a routine can also help reduce stress in the caregiver. Managing and administering medication, ensuring medications are taken on time and correctly is vital, especially as cognitive decline progresses. Emotional and social support. Emotional connection helps reduce feelings of isolation and depression in patients, which is often seen. Providing emotional support to Alzheimer's patients is crucial for their overall well-being and quality of life. It helps them cope with the challenges of the disease, reduces feelings of isolation and anxiety, and it can even improve cognitive function. This support also helps caregivers maintain their own emotional health and well-being, which is essential for providing quality care. As we all know, you cannot pour from an empty cup. Caregivers also play a pivotal role in managing behavioral symptoms such as aggression, wandering, usually by educating themselves on how to handle the behavior, as well as showing empathy and patience. Caregivers also assist their loved ones in expressing themselves and understand others as language skills decline in this journey. If this goes unchecked, frustration and misunderstandings stemming from communication difficulties can lead to isolation, anxiety, and behavioral changes. By actively supporting communication, caregivers can help preserve a person's dignity, self-esteem, and connection to the world around them. The safety and environmental modification. Modifying the home for safety is crucial for the well-being and safety of their loved one. It helps prevent falls and injuries. It helps reduce stress for the caregiver, preventing hospitalization of their loved one. It also helps maintain a degree of independence for the person with Alzheimer's. Maintaining a home free of clutter is the best way to prevent a safety hazard. A safe and organized home environment helps the Alzheimer's patient feel less anxious, which can positively impact cognitive function. Reducing confusion and disorientation can improve the ability to navigate their surroundings and engage in daily activities. Monitoring the patient's movements and behaviors. It helps identify potential safety risks, early signs of complications, and opportunities to provide more effective care. Mhm. All right. Safety, when it comes to monitoring movements, especially in wandering or nighttime activity, can help prevent falls, injuries, and the risk of eloping from home. Alzheimer's can cause significant changes in behavior, including agitation, confusion, and changes in sleep patterns. Monitoring these changes can help caregivers understand the triggers and develop strategies to manage them effectively. Early detection is important. Regular monitoring can help identify potential infections, medications, side effects, or other medication size. 1 second, please. Okay. Health advocacy. Accompanying the patient to doctor's appointments, communicating symptoms, and following through on treatment plans. This ensures the individuals receive the best possible care that the caregiver receives, support and guidance, and that the caregiver's own well-being is addressed. This can also help the caregiver connect to a social worker within the medical team, helping address certain issues and guiding the caregiver to community resources needed. Coordination of care between doctors, therapists, and support services is important because it ensures comprehensive, holistic care, minimizes caregiver stress, and improves the quality of life for both the person with dementia and the caregiver. By collaborating, these professionals can better address the individual needs of the persons with Alzheimer's, manage their symptoms, and provide support to the caregiver, ultimately leading to more positive outcomes. It also helps reduce caregiver stress, improve quality of life for their loved one, and prevent recent hospitalizations. Recognizing and responding to health behavioral changes in people with Alzheimer's is crucial for caregivers because these changes can be indicators of underlying issues, such as infections, pain, or medication side effects. And it can significantly impact the individual's well-being and safety. Additionally, understanding the triggers and causes of behavioral changes can help caregivers manage them effectively and create a more comfortable environment for their person with Alzheimer's. It can help in promoting independence and safety. For example, recognizing wandering as a sign of confusion and disorientation can lead to implementing measures to prevent wandering and ensure the person's safety. Yeah. Behavioral changes are often triggered by changes in the environment, sometimes pain and emotional distress. And understanding the root cause, caregivers can implement strategies to reduce the intensity or frequency of the behavior, making it easier to manage and reduce stress for both the person and the caregiver. Legal and financial support, which is very important. Individuals with Alzheimer's disease often need help with legal documents, especially power of attorney and healthcare proxy for several reasons. Preserving the individual's autonomy and wishes. A power of attorney allows an individual with Alzheimer's while still having legal capacity to choose a trusted person or agent to manage their financial and legal affairs when they can no longer do so themselves. A healthcare proxy, for example, also known as a healthcare agent or surrogate, lets the individual appoint someone to make healthcare decisions on their behalf if they lose the capacity to do so. These documents ensure that the individual's wishes regarding finances, healthcare, and end-of-life care are respected and followed, even after cognitive abilities decline. Having advanced directives in place is beneficial to avoid future complications and legal battles, as well as simplifying financial management and access to healthcare. Alzheimer's affects memory, decision-making, and ability to think clearly, making individuals very vulnerable to scams and financial mismanagement. This vulnerability, coupled with the potential for exploitation, can significantly impact the well-being of both the person with Alzheimer's and their caregivers. Protecting the individual's assets is important. Maintaining financial stability, ensuring future care, preventing scams and fraud. Early planning power, helps protect the individual, and having a designated power of attorney, monitoring finances, limiting credit card access, and having an alert system for financial information is really important. And this is a big one, which I always also stress a lot with my caregivers, is self-care and education for them. Learning about Alzheimer's disease and other forms of dementia is crucial for caregivers to provide effective and compassionate care. Understanding the disease's progression, symptoms, and the unique needs of individuals with dementia helps caregivers anticipate challenges, develop appropriate coping strategies, and ultimately improve the quality of life for both themselves and the person they are caring for. Support groups for Alzheimer's caregivers are beneficial because they provide a safe space for emotional relief and share experiences, which can significantly reduce stress and improve overall well-being. These groups offer a network of peers who understand the unique challenges of caring for someone with Alzheimer's, allowing caregivers to connect, share advice, and find solace in knowing that they're not alone. Other benefits of joining a support group are share experiences with others, reduce isolation, which we know that dementia can be a very isolating disease. Empowerment and advocacy. Practical advice and resources can also help reduce stress for caregivers and increase understanding of the disease. Self-care for Alzheimer's disease is very important and vital to prevent burnout and sustain their caregiving efforts. Because, like I said before, you cannot pour from an empty cup. It also addresses physical, emotional, and mental toll of long-term care planning. When caregivers prioritize their well-being, they are better equipped to cope with the challenges of Alzheimer's care, reducing the risk of stress and anxiety and depression, which can be seen a lot. Furthermore, self-care enables caregivers to maintain their physical health and energy levels, allowing them to continue providing effective care. Self-care helps with improved mental health. It helps make the relationship between the caregiver and the loved one even stronger, improving physical health, and they have more energy to be able to care for their loved one and be at their best at it. So what can we do? We can start by recognizing caregivers, by checking in on them, supporting them, advocating for better services, and removing the stigma around seeking help. Caregivers are the silent strength behind many families. If we want to truly care for people with Alzheimer's, we must also care for those who care for them. Thank you.
Thank you so much, Paola. That was really great. Here's her contact information if
Yes.
anybody wants to reach out.
Yes.
That was wonderful. I don't see that
Any
anybody has
questions?
any questions for Paola. We can move on to Jeff, and if you guys do have questions for Paola, we can answer those as
Yes.
well, after Jeff has finished speaking.
Thank
So
you.
thank you so much again. That was
Thank you, everyone.
wonderful.
Thank you.
And I think that's a really great segue into hearing from one of those folks who was a caregiver,
Yeah.
and his experience of getting and not getting the support that he needed. So, Jeff, I will turn it back over to you. Thank you.
Thanks. I'm glad to pick up from there. Let me see if I can do the share screening thing right as well.
And I'm happy to share if you'd like as well, if it gets
I
stuck.
think I've got it. Could you confirm?
Yep, I see it.
Beautiful. Okay.
Great.
So, I'm happy to to bat last in this. Um, I hope you've gotten as much out of Dr. Cohn's and soon to be Dr. Brundage's and Paolo's talks as I did. And in a way, what I'm going to do is actually repeat their talk, not because I want to be repetitive, but because so much of what I have to say reflects very directly on what they've all shared, except that I'm going to do it from a completely opposite perspective, where you've been provided with this wonderful, general, broad clinical advice. I'm going to provide a perspective that's incredibly specific and personal. Um, I've given many presentations in my life professionally. I'm in the investment business, and I'm sure I've given hundreds of presentations, as well as done many for the Alzheimer's Association as well. Um, when I give such presentations, um, even though I'm not a medical professional, I feel like I live in a parallel world with you guys because I'm very data driven, I'm very factual, I'm very statistically oriented, very objective. And this is going to be a very different presentation. As I say, it's going to be subjective. In the process of describing my caregiving journey with Patty, my wife, um, I'm going to attempt to nudge you guys a little bit out of your comfort zone, and I'm going to apologize in advance for doing that. Um, One of the last things you should ever do in a presentation is to make your audience uncomfortable, but I'm going to do that in the hopes that if I'm effective at doing it, it will help you think a little bit differently about how you provide care to persons living with dementia and their caregivers. And to make it a fair bargain, I'm going way outside my comfort level to do this. So hang with me, and we'll go on this journey together. I'm going to start with a poem. Patty and I met in a poetry writing workshop 48 years ago, believe it or not. So this poem sets the tone for what I want to talk about today. It's called Into the Woods. We have not moved, yet here we are somehow, not knowing quite how we got here, living on the edge of a forest. These woods are not lovely, though they are dark, dark and deep. And you have never been a frontierswoman, but every day now you take a walk in the woods. You take no heed of my warnings. It is a wilderness, without trails, without paths, without ways of coming and going, only traces of steps wild creatures have trodden before you. I want to follow you, to accompany you, to walk beside you, but as frail as you are, you leave me far, far behind. When you return, you cannot say where you've been or what you've seen, and I know against my wishes, you will venture forth alone again tomorrow and the next day and the next day after that. And I know that each day you will wander deeper into the woods, without destination, without purpose, driven, impelled, incapable of stopping. And I know one day, soon, all too soon, you will not return. I wrote that poem when my wife was deeply into stage 6, and I wrote it to try to understand where we were and what was happening and what the future would be. So let me start by talking generally about Alzheimer's disease and caregivers in particular. Without wanting to repeat what we covered earlier, I'll just focus on 2 or 3 things that speak very specifically to a caregiver's journey. And that's that the average survival rate for somebody with Alzheimer's is 4 to 8 years after symptoms appear. This is a long journey. And some individuals live 10, 15, even 20 years with it. And 80% of adults living with Alzheimer's are receiving care in their homes. Again, from our comfort zone statistically, what can we say about caregivers? There are 12 million Americans providing care for individuals with Alzheimer's, and that's over 18 billion hours of caregiving each year. And as Paula just mentioned, caregivers face incredible risks to their own health, depression, chronic conditions, emotional stress, physical stress. The average Alzheimer's patient caregiver spends 1 to 4 years more caregiving than caregivers for people with other diseases. And in the Harvard study, up to 40% of Alzheimer's caregivers don't survive their loved one's illness. So it's a major issue. Caregivers as well uh, express great difficulty finding the resources they need. So I'm going to go from 30,000 feet, caregivers generally, to me very specifically as a caregiver and introduce myself. I am the head of investment strategy for Community Bank, PPAC Private Bank, where we manage $12 billion of assets for individuals and their families. I've got an MBA from Columbia. I did undergraduate work at Columbia as well. I'm a certified financial planner. And what that means is we help individuals define their financial goals. We map out a plan or a strategy for how to achieve those goals. And then we manage their assets again in order to accomplish the plan objectives. If I showed up in your emergency room, your intake person would describe me as a 68-year-old white male presenting with stress, a history of hypertension, and coronary artery disease. This is a bio, this is a resume, this is factually who I am, and this is how you're probably used to interacting with folks like me. But it's not even slightly who I am, it's just what I've done. This is who I am. In my personal life, I'm a widower, I'm a stepfather, an uncle, a brother, a friend. I'm the parent of an 11-year-old English Golden Retriever that does pet therapy in nursing homes and with children in libraries. I like to stay in shape, so I bike and I play tennis. Spend a lot of time volunteering for the Good Dog Foundation and for the Alzheimer's Association. My special quiet place is in my garden. I'm an avid reader. I like to play the piano and sing, and I'm an inveterate punster. We used to think it was being clever with words. Now it's devolved into only dad jokes, and I'll spare you them for this presentation. First thing I want to tell you about my experience as a caregiver is 15 minutes is not enough. I can't change the healthcare system, and I know you guys individually can't change the healthcare system either. But if you look at the photo on the right side of this slide, what you see is a patient who looks extraordinarily lost. And you see a woman, his caregiver, perhaps his spouse, who is looking at him with a great deal of love and a great deal of concern. What's the takeaway from this photo? You've got two people in your office, in your room, and the needs of patients with Alzheimer's are such, the nature of this disease is such that each patient is unique. They've got a unique set of symptoms, and um, and the needs of both the patient and the caregiver can't be met in the 15 minutes that's currently slotted or allowed to them. There's far more, too much complexity going on here. A few things I want to convey about the caregiving experience, at least as it was experienced by me. I'm embarrassed in a way to say these things. They seem so obvious. But as obvious as they are, they may be also profound, and I'll explain them in a little more detail. Caregiving is hard. It's lonely, and it's really, honestly, heartbreaking. Why do I say it's hard? It's hard because your loved one is disappearing right before your very eyes. It's hard because this disease progression is relentless, and it's also unpredictable. There's an endless series of losses a person living with dementia experiences, and the caregiver experiences every one of those losses keenly, painfully. And it's not just, of course, a physical illness, as mentioned, emotional, behavioral, psychological components of it as well. Not only is it hard, but it's lonely. It's lonely because you're losing your parent, your sibling, your spouse, your best friend. In my case, Patty was my best friend as well as my wife. It's lonely because it may be surprised, but one loses family members and friends on the way who you thought were there for you. But in actuality, many of them find it's just too hard for them to deal with, and they drop away. It's hard, lonely also because caregiving is so demanding that we as caregivers tend to drop our own social activities to meet the demands of our loved one. And ultimately, whatever activities you engage in, whatever help you engage with, you're alone with your loved one. So, a few notes on what the caregiver experience is. And finally, the thing I really want to convey as keenly, as profoundly as possible, is we have to stop thinking about cases. We have to stop thinking about patients. We've got to start talking about and thinking about people living with Alzheimer's disease as people. And with that, I'm going to introduce you to my wife, Patty. I'll start the way we all start, with data. Patty retired as Associate Dean for Institutional Advancement at Bank Street College of Education. She had 2 master's degrees and she did all the coursework towards a PhD. She just didn't get to the dissertation. She was an educator, a grant writer, and a fundraiser. But again, this is just sort of a resume type of description of who she was. Let me reintroduce you to her on a more personal basis. Patty immigrated to the U.S. as a 12-year-old from Hollywood, Northern Ireland. When they tested her for school placement at age 12, she tested as first-year college. That's how brilliant she was and how well educated she was at age 12. She was an amazing wife, mother, stepmother, and sister. She was an amazing cook. She would read Bon Appetit and gourmet magazines cover to cover, looking for the most incredible recipes because for her, food was love and she wanted to really please her family. She was a wordsmith, a poet. She was an avid reader. When Patty and I would go to California on a plane trip, she'd need a separate tote bag just to carry her books. She'd complete 2 of them just on one transcontinental flight. She loved doing crossword puzzles, but only the Friday and Saturday New York Times uh, uh, puzzles in pen because the rest of them were too easy. And she really enjoyed fine French wine. What happened to Patty in the course of the disease? Well, Patty stopped remembering how to make soda bread, which she had made since she was a small child. She could no longer follow the steps in a recipe. When she started having reading difficulty, she couldn't remember the beginning of a paragraph by the time she got to the end of that paragraph. And the Patty who couldn't read was no longer really Patty. She could no longer do not just the Friday and Saturday Times crossword puzzle, she couldn't do the Monday crossword puzzle. And her enthusiasm for good French wine turned into self-medication as awareness of her disease progression weighed on her. I'm going to play now a short video for you, and it should come with a warning as you get on news channels that some people may find this difficult to watch. But I'm showing it to you because I think it illustrates, this is within 6 months of Hattie's passing. It'll be clear to you the deficits in language and in thinking that occurred to her, but I'm hoping as you watch it, you'll see something else as well.
Good things. You could do more good things, couldn't you? Yeah, I think we could because we were putting things what we can do because we were doing things with people. We were doing good things, right? Yeah. And we enjoyed it. So we're going to be looking forward to thinking about how we're going to put plenty of what? We'll just keep it up. Yeah. We'll keep it going. Work. Work. Much more improve. Mm-hmm. Yeah, that's the way it is, isn't it? Yes. Yeah. And it's all right that way, isn't it? Mm-hmm. Yeah. You look great. Yeah. Love you, too. Thank you, better. For you? Yeah. I was doing. Yeah, what were you thinking about it? Yeah, and I did feel that I couldn't possibly ever do it. No, just not possible. No. Okay. That's okay too. Do it. Yeah. Why not? Love you. Too much. Good. I think it's good too. I'm glad. I'll do it always. And I can be.
That's a painful video to watch, certainly painful for me. But I hope beyond the disease progression that's so apparent there, you see something else. You see Patty's humanity. You see the person that she was, still there, still reachable in part. Thank you for watching that. I want to talk now about what the diagnostic process was for us, particularly as it relates to you as primary care providers. Patty experienced several years of progressive memory deficits. In her annual screening, there was no investigation of cognitive changes. Patty got lost going to the dentist, where she'd gone many times before, and I ultimately requested, and her primary care physician did ultimately refer her out to a neuropsychologist, given these concerns with memory loss. The psychologist did a careful evaluation, and at first glance, you'd say not so bad. She did 25 out of 30 was her score in her initial MMSE, but she couldn't name the county and the town that she was living in. She'd clear episodic memory disorders. She couldn't learn new information. And the diagnosis was mild cognitive impairment, suggestion that the underlying disease etiology was early stage Alzheimer's, with a suggestion or referral out for further diagnostic testing, which we proceeded to do. We had an MRI done and a PET scan done. And this is the radiologist's report or selected segments from it. Now, I've got an undergraduate degree from an Ivy League school, summa cum laude in English, and I couldn't make much sense out of this medicalese report, but I could understand a few things. The volumetric analysis put her at the first percentile for age, and I'd taken statistics. I knew what the first percentile meant. It was remarkable to me that she was functioning at all with such dramatic shrinkage of her brain. In addition to a diagnosis of Alzheimer's disease, they found ample evidence of advanced cerebral amyloid angiopathy and brain aneurysms. So it was a complicated diagnosis. I want to talk more about that diagnosis. And what I want to say to this audience is that no one is diagnosed too soon. By the time we get to your office, we know there's a problem. And when you confirm what we already know, we need you to be brutally honest with us. We need you to tell us this disease is progressive, this disease is fatal, and you're going to experience a lot of challenges along the way, and you're going to need a lot of help dealing with it. And because of the neurocognitive elements of this disease, it's going to be a disease journey unlike any other. And that whatever guidance you can provide every Alzheimer's patients' journey is different, notwithstanding commonalities amongst them. It's a devastating diagnosis, and I'm going to make a comparison with another devastating diagnosis, cancer. We used to not even refer to cancer directly. We used to just say the C word. But for a number of communities, Alzheimer's disease is also something not to be much talked about. With cancer, we've had remarkable advances in the science so that biomarkers, immunotherapies, the ability to give very targeted treatments are such that in many cases we can achieve remission or even cures. But with Alzheimer's, our understanding of the disease and our ability to address it is poorly understood. We don't have cures. We don't have medications that address the disease itself, much more so only on symptom management. Treatment options for cancer are laid out. Treatment benefits and side effects are weighed, and a plan is set forth. Most frequently with an Alzheimer's disease, the diagnosis is given, but there's no care plan after that. With cancer, in most cases, there's very limited cognitive impact. Obviously, cognitive impact is a lot of what Alzheimer's disease is about. Family support is helpful, certainly for cancer, but family support is critical, as well as advocacy for Alzheimer's disease. There's significant help navigating the healthcare system at major cancer centers. Most families have to navigate the healthcare system on their own when they're dealing with dementia. And finally, health span and lifespan may align pretty nicely with successful treatment of cancer. With Alzheimer's disease, lifespan may extend greatly beyond health span. I want to talk to you a little bit about our experience with neurology. Maybe it's great that Dr. Cohn isn't here to hear this because somewhat similar to what we heard from David and Zipporah this morning, we had what I would call relatively discouraging experiences with neurology. I'm not blaming individuals with that. It's the state of the science that isn't offering a lot of help. But our first neurologist was local. We would have semi-annual visits. The MMSC was performed, clock drawing was performed, all of this in order to track Patty's disease progression. But what I would say about that is it was an incredibly unhealthful experience. The very first visit, Patty was unable to do the clock drawing. And on subsequent times, it was simply an exercise in frustration, both for her and for me, witnessing her struggle with it. So, wanting a second opinion, I found another neurologist, this at one of the major medical centers in New York. Given the complexity of Patty's diagnosis with CAA and aneurysms as well, she was deemed ineligible for all clinical trials. We were told, go home, adopt a Mediterranean diet, get some exercise, do some brain puzzler types of exercises to try to keep the brain active. That wasn't much by way of a care plan. We already ate pretty well. Patty hadn't been big on exercise, but I did find a personal trainer who specialized in working with individuals with cognitive issues. And for a few months that worked, but then Patty lacked motivation, lacked energy, um, uh, had apathy, and discontinued the exercise. And at that stage, her disease was sufficiently advanced, she couldn't do brain stimulation exercises. But in desperation, I turned to yet another neurologist whom I heard about. And like Zipporah, this one was a concierge doctor, Park Avenue practice, no insurance, no Medicare, but we were lucky enough to be able to afford to do it. And this neurologist was doing some unconventional treatments, which in her clinical experience nonetheless had positive impacts. When she tested Patty, she found Patty had remarkable language reserve, given how far her disease had progressed. And she proposed doing electric brain stimulation. We agreed to it, desperate, as I say, to have any solution that might extend Patty's brain function. But as the electrodes were being applied, she hollered as she had never hollered in her life. We couldn't even conduct the first session. And at the end of the day, all the neurologist was doing was medication management for symptoms. So let me describe Patty's journey. Patty and I took a trip to Africa a year after she was diagnosed. It was the trip of a lifetime, but it didn't turn out as well as I hoped. When we went to Victoria Falls, which were dramatic and amazing, she was so terrified by them that we had to cut our visit short. And when we went on a game drive on safari, coming upon two lions as they were awaking at dusk, they were fascinating, stretching, growling. I was riveted like I was in a National Geographic, but we were in a Land Rover, 15 feet from these lions. Patty couldn't be less interested, and she just looked away from them. Executive function. Patty lost all financial sense. She would go to get a manicure, and she would give a tip larger than the cost of the manicure. I tried to provide more social activity for Patty by enrolling her in a superb quality adult daycare facility. She didn't last an hour. And when she came home and saw the brochure on our kitchen table for my second home, she scrawled on it, "I don't need a second home. I like my first home." Neurologists became concerned about whether it was safe for Patty to drive, and we did go to Burke Rehabilitation, as Dr. Cohen mentioned, and they did a very thorough evaluation. I was very impressed with it, both in the facility and then out on the road test. And shockingly, Patty did pass. But Patty couldn't find her way home from 3 blocks away, so she had to give up driving. She did have delusions, as Katie Brendish talked about. She was always wanting to go home, although she was in her home. And I came to understand that that meant that she wanted to go back in time to a place where her understanding of the world and her security in the world was greater. She would say, "I want to see my mother," who had been deceased for over 15 years. That's when I learned about not contradicting or correcting or trying to bring her back to reality, but rather going to her reality, and redirecting as needed. Patty had a sense that more people lived in this house than just the two of us, and she was always wondering where they were. Hard to explain to her because she didn't believe it that nobody else lived here. We used to enjoy going to the farmer's market locally. But one day, Patty decided that the other people at the farmer's market were out to hurt her, and it was no longer a place that we could safely go. What else? This woman who had this amazing command of the English language ended up speaking in word salad. You could understand individual words, but not when they were strung together. She became very fearful, and I would ask her what she was afraid of, and she would say, "Everything." Gradually, one by one, she lost activities of daily living. First, she couldn't pick out her clothes, then she couldn't put them on, then she couldn't bathe herself, then she couldn't feed herself, then she had toileting issues and incontinence. Patty had a number of falls, including one that left her with fractured ribs and another where she fell out of bed, gashed her head on the night table, and had to be rushed to the emergency room. She experienced extreme weight loss, ultimately had swallowing issues, which in turn resulted in aspirational pneumonia, and eventually hospice came in to give us help. I mentioned earlier 3 of the things that are really hard about caregiving, and one of them is heartbreak. I'm going to read you a few things Patty said. I took some contemporaneous notes as we were going through this journey, and I think I'll give you a sense of how hard it is for the patient. In order to have context for these, I'm going to give you an analogy first, though, because there were times when it seemed like Patty was understanding her situation. It seemed at other times like she was partially understanding it, and at other times not at all. And the analogy I use is of an old lamp with a frayed cord. You know how when you plug in such a lamp, the light may go on, it may flicker off, may flicker back on. And if you keep doing that over time, the light goes on less and less, it flickers more and more, then eventually it doesn't go on at all. That's what it was like with Patty in progression as her awareness of her situation declined over time. And in some ways, it was less painful when she was no longer aware. But when she was aware, it was absolutely heartbreaking. She said, among other things, "You won't give me away, will you?" And I understood by that. She meant I wouldn't place her in a facility. She said, "I'm afraid of myself." She said, "I'm afraid of getting lost and not finding my way." She has said, "I have things in my life around me and I don't know how to hold them together, and I want to." She said, "You won't give me away, will you?" She said, "I'm afraid of getting mixed away." She said, I think I'm okay, but I'm wrong. And I'm afraid I'm going to disappear." And of course, she was right to be afraid of that. I want to make one more comment about the heartbreak of this disease. It comes from Pauline Boss, a psychologist who developed the concept of ambiguous loss. And it's a loss in which there's no closure. In the context of Alzheimer's disease, a person is physically present with you, but they're emotionally or cognitively absent. It's a very hard, difficult situation to live through. There's no closure in it. There's no grieving in any formal sense, but there's a lot of grieving that people who love somebody with dementia are undergoing. That was Patty's progression. I'm going to talk about mine now. When we got this diagnosis, I did what I do in my professional life. I researched the heck out of it. I realized how little I understood and how much I needed to learn. I went through stages of grief, not denial, because that's just not my bag, but bargaining and so on and so forth. And I had to come to accept that the cavalry isn't coming, which is to say, there's no solution to this. I'd say that societally, we don't raise men to be caregivers. And so in some ways, it's harder for us because it's not our natural go-to. We're trained instead to fix things. And we're trained as well not to ask for help, but to be independent. But with Alzheimer's disease, there's no fixing this. And you need a heck of a lot of help to get through it. Desperate for solutions as I was, the solutions didn't exist. I did eventually join a caregiver support group. It was all of the things that Paula mentioned, incredibly helpful from the perspective of hearing from and relating to other people undergoing the same experience. You know, the Alzheimer's Association provided multiple opportunities for us to engage with others, to to hear music played and to get out of the house. When Patty's diagnosis occurred in 2017, I was operating an independent financial advisory firm with a partner, and I realized I couldn't maintain the commitment and the amount of time I was devoting to it. So within 6 months, I sold my firm, although I did continue to work. I told my partner, but I didn't tell anybody else about my wife's disease. I didn't tell clients because I didn't want them to think I was going to pay less attention to them and be less available to them. And I came afterwards to understand that that was a mistake. I've worked with many of my clients for 25 years or more. Many of them I consider friends. They consider me friends. Patty passed, and I later told them that she had passed. Yeah, they were incredibly sympathetic, but they were also hurt that I hadn't shared with them what I was going through. I faced difficult decisions. Do we move or not move? I know how important it is to maintain a stable environment, and Patty really, really loved our home. But she no longer recognized our home as such. She didn't know how to get from one room to the next. And we live in an old three-story house with nothing but a small powder room on the first floor. And I worried, as Patty's mobility declined, how would we be able to live in this house? During this Alzheimer's journey, I had major surgery on my cervical spine. I had 3 discs removed and some fusion done. I thought at the time, or maybe I didn't even think about it, it was just something that needed to be done. I've later come to think, how much did stress advance my neurological decline, necessitating that surgery? I hired an aide to help with Patty because I did continue to work. I needed the socialization and the stimulation. And Patty, soon enough, couldn't be left home safely on her own. So I'd work during the day. I'd come home, I'd fix dinner and feed Patty, toilet her, and put her to bed. And I realized that my life had turned into work, caregiving, work, caregiving, work, caregiving. I hired a second aide for weekends so that I could do some of the things that would help me stay reasonably sane. And I am proud to say we were able to keep Patty home throughout to all the way to the end of her Alzheimer's journey. Few takeaways, things that surprised me as a caregiver, how completely unprepared I was to be a caregiver, the range and extent of Alzheimer's related deficiencies. It's not just the memory stuff that everybody knows and expects. It's spatial cognition, balance, and so on and so forth. It was eye-opening to me how little traditional medicine had to offer. At that point in time, Patty was put on a standard dose of memantine and donepezol. Did it help? I'll never know because that's counterfactual to imagine would she have progressed any more quickly without those medications. Uh, but after that, all we were doing is treating symptoms. It did surprise me how close friends and family members were not able to be on the journey with us. I would say that the unpredictable and endless series of losses was something I had no awareness of before I started this journey. I did understand that my wife might well forget who I was, and she did. I had no idea what that would actually feel like. And then finally, I did learn the virtue of going to patients' realities, that therapeutic lies or fiblets were really an important way to manage or reduce or avoid agitation and anxiety. What do I want to convey to you? What's my ask of you? I think there's no higher calling in the world than the medical profession, than caring for people as you do. So I feel guilty asking anything more of you than you already do. But I will say that I love the knowledge, the clinical experience, the professionalism that you bring to your work every day. I think for patients and caregivers, you could enhance our experience with you with more empathy and more compassion. There's no need to hide behind the white coat. We know you're credentialed. We know how smart you are. But the professional detachment that helps you manage day to day with the hard work that you do is distancing when we need connection. Medicine is often managed in isolation and silos, and we need connectivity, we need collaboration. We understand that medicine as it's practiced today with relative value units and volume approaches and so on may be a financial necessity, but it comes short of being patient and quality centered. Where you're forced into being templated, we love to see you be more flexible, to be more individuated. And where the focus is on physical symptoms, it's important to recognize that this disease covers so much wider spectrum of issues that need to be dealt with. I want to end on a constructive, upbeat note. There were unexpected gifts I had as a caregiver. I learned gratitude. I was grateful for ever so many things, even as our journey was very challenging. I was grateful that my wife didn't experience extreme agitation, that I wasn't a trigger for her, as sometimes happens, that we had the resources to hire good help. Evelyn, who was her primary aide, stayed with us 5.5 years through our journey with incredibly loving care. And every morning when I get dressed, I sit down on a bench, put my socks and shoes on, and I'm lucky enough to have a view of the Hudson River, and I look out and I say, boy, am I lucky, notwithstanding what I've been through from Alzheimer's. I learned advocacy. Alzheimer's patients can't advocate for themselves. So somebody's got to do it. And the healthcare system has sufficient bottlenecks that somebody needs to be an advocate for Alzheimer's patients. I learned that Alzheimer's disease can pull families apart, tear them apart, or it can bring them together. In our case, mid-stage of Patty's journey, we began to have weekly Zooms since our family is scattered across the country and, in fact, across the globe. And that was in 2021. Patty passed away 18 months ago, but we still get together on a weekly basis, and we've been drawn closer together as a result of having gone through this experience. And finally, I learned and became part of a community of caregivers and people who support caregivers. I had lunch this week with a woman in my caregiver support group whose husband passed away 3 years ago. We have a bond that will never die because of what we've been through together. So, going forward, Patty's Alzheimer's journey ended November 24th, 2023, and we scattered her ashes in the ocean as she wished. But my journey as an Alzheimer's caregiver continues. I feel a deep commitment to try to make this caregiver journey less arduous for other caregivers. And I hope you'll join me in thinking about ways in which you can do the same. In the words of Maya Angelou, you can be the rainbow in somebody's cloud. So thank you for listening to my presentation. If there are any questions, I'm happy to address them.
Thank you, Jeff, so much. That was so powerful. And, I've already told you this, but I love the way you shared it as a case study, like we've talked about a lot today, but then really brought the humanistic side back to the conversation. So thank you for sharing that very moving and very personal story. One thing I do want to mention while I give people time if they have questions, as part of the guide program pilots that are happening around the country, the Alzheimer's Association is actually creating an Alzheimer's Navigator training, which should be coming out this summer. So that's really exciting. And I think you hit the nail on the head. That is something that is absolutely needed by families and usually falls to the care coordinating department or, case management, but they don't always have the time and resources, I should say, to do it as well as those cancer navigators do. So thank you. I'm not seeing any questions. Sandra, do you have some evaluation information you need to share with everybody before we close out? She might have stepped away. All right. Well, oh, we have one comment. No questions, but sincere thanks for sharing such a personal story. Very valuable to see it through the eyes of a caregiver. Thank you, Sam, for that comment. That is exactly the intent. Not getting lost in the labs and the tests and the what you can and can't do, but just that the folks facing the disease are people and their caregivers, do a lot to make that maintain. And it's hard to keep with that when you get lost in the medical and sort of that complex side of things. So thank you for that comment. I don't think we have anything else, so I just want to thank you guys very much for joining us today. Hopefully we'll be able to do something else like this in the future. So hopefully we'll be able to, continue this education. If you do have any questions or would like more information about any of the topics today, please feel free to reach out to me or Sandra at Montefiore Nyack. Thank you, Sandra, so much for getting this set up on the Zoom today. Even though we had technical difficulties, we made it through. So I appreciate all of your support in creating this great agenda for the CMEs. I'm sure Sandra will be sending out information on how to claim those. So with that, I will say thank you again, and hopefully we'll see you guys all soon. Thank you very much for joining.